Mi senti? Sei muto? Non so se mi senti o no.
Sì, ti sento e ti vedo
Ah,
io. Sei un po' bassina con la telecamera, esatto, alzati un pochettino.
ok.
Alessandra e Marco, buon
Buonasera.
pomeriggio. Ben trovati.
Ciao. Eli,
Aspettiamo.
Ciao, non riesco a condividere, mi dai l'abilitazione e anche a loro se non ce l'hanno, per favore?
Daniela, buonasera a
Ciao.
tutti.
Sì, ok, ora sì.
Prova a condividere le
Ciao,
slide
Elisa.
adesso. Ciao Mariano.
Ok, ora sì, grazie.
De nada.
Almeno
Sì.
finché aspettiamo. E Alessandra, Marco, volete provare a condividere le vostre? Interrompo la mia, era solo per mettere uno sfondo.
Allora, è impossibile iniziare a condividere mentre l'altro partecipante effettua.
Ecco, ora dovreste poterlo fare.
Cioè, condividi tu?
Sì. Allora, inizio dalla prima, che voi adesso vedete, immagino.
Che è l'ultimo, però sì, ok.
Ok.
This meeting is
Va
being
bene?
recorded.
Sì, ma
Ok.
sulle tue c'è quella modifica che ho fatto sugli antivirali, no? Sì. Non su
Guarda,
questa. sulla
io
tua-
ho lavorato sull'ultima che mi hai
Dedicated. Ok. I start again for the recording. Dear all and good afternoon. Thank you for your participation in this training afternoon dedicated to improving health literacy and protecting the value of access to care about COVID-19. This pandemic has taught us that how much damage an informed citizen and patient who perpetrates unhealthy health-related behavior can cause, and how much, on the other hand, uninformed citizens and patient can make the difference not only to his or her individual health, but to public health in general. Day-to-day activity is realized in the framework of two projects, both supported by a Pfizer unrestricted grant. The first one is protecting the value of access to care during and after the COVID-19 pandemic across Europe, focused on antivirals, and is led by ACN. While the second one, improving health literacy for better public and patient involvement in COVID-19 pandemic mitigation, is led by IAPO, P4PS Observatory, with the involvement of IAPO, the International Alliance of Patient Organization, with the Italian NGO Cittadinanza Attiva through our ACN, ALSER, as the Spanish Federation of Association Fighting Kidney Diseases, and Studiorum, the Macedonian Center for Regional Policy Research and Cooperation. Day-to-day training, as I said, is addressed to representatives of patient advocacy groups and civic associations coming from different European countries. And it wants to allow to provide a common set of updated data, share information, identify the lessons learned, but also to obtain feedback from you. There will be two separate sessions. The first one about knowing and mitigating the impact of COVID-19, and the second one most focused on the value of access to care and the use of antivirals. The trainers that will lead us in this afternoon are Alessandra Medolla, general practitioner out of our service in the Salerno city and member of the National Cardiovascular Area of the Italian Society of General Medicine and Primary Care. And Marco Vatri, general practitioner out of ours, resident in geriatrics at the Careggi University Hospital of Florence. For ACN, my colleague Bianca and me will moderate the event. So please, Alessandra and Marco, the floor is yours.
Thank you. Good evening to everyone.
Good evening.
I'm going to share our presentation. Okay. I hope you can see. Okay. I hope you can see correctly my slide, my presentation. So let's start from the beginning. We think it's the thing that we have going to speak about are in part very a little bit hard to understand if we don't know if you don't have the basic knowledges about the virus and what the virus do, how the virus is. And the aim of the virus life is the replication. And the virus is very different from the bacteria and other pathogens because this is not a cell. The virus doesn't have the structure, the mechanism to replicate itself. So it needs the cell. It needs the human body cell in the case of SARS-CoV-2 to replicate itself. And to provide an infection, it needs to avoid the immune system and avoid therapies. So it has to avoid all the obstacles to the infection. So what is a virus? The virus is only a genome surrounded by a capsid, an envelope that is made by proteins. And when we talk about the genome, it's important to understand that a genome is only a set of information. It's like a code. And we have to translate the code into proteins. And in the virus use the cell as a factory, as a virus factory to reproduce itself. So when we talk about a mutation, the mutation is on the genome because the gene has to be translated in protein. So when we do a modification of the genome, the protein will change in shape normally. The mutation is the surviving mechanism of every virus, and the SARS-CoV-2 has a low rate of mutation if we compare it with other kind of virus. The genome modification providing better capacity to infect the cell, provide a disease, immune escape, and therapy escape. But which is the part of the virus that mutate in particular? This is it seems very complicated, but I'm going to make it simple. I try. The first line is the virus genome, and in particular, the major part of the mutation are due to S protein. The S protein or spike protein is the protein that we find on the envelope of the virus. And this is very important site of the virus because it allows the virus to penetrate the cell on the first line, and it is immunogen, so it stimulates the immune system, and in particular this is the main important part of the S protein that bind the receptor of the membrane of the human cell. The RBD is like a key that open a lock, and the lock is the receptor on the cell, on the human cell. So the mutation on the RBD are important because this allows the virus to penetrate the cell and provide the infection. You can see in this image, it's more clear, I think, to see what is and how it works. So this is the spike. The spike is remind us the spike of the crown, so the name coronavirus. And this spike is immunogen, so stimulate the immune system to produce antibodies. At the end, the antibody recognize the spike protein and help the immune system to neutralize the virus. So it's easy to understand how the mutation help to avoid the immunity activity, because is the spike is what at first provide the immune stimulation. On the second hand, as I have told to you, the S protein binds the receptor, ACE2 is the name, and make possible the penetration of the virus. So why do you talk about it? Because the mutation that priorly regard the S protein modificates this activity, the immune stimulation, and the ability of the virus to penetrate the cell. So this is not very important to talk about the all type of Omicron variants, but we know that the Omicron is a variant of concern. What's the concern? The most alarming insight is the ability of this variant to escape the immune system. And this is related to the ability of the virus to escape the vaccine efficacy, to decrease the vaccine efficacy. Because the vaccine at the end stimulate the production of antibodies, and these antibodies recognize better the wild type spike protein. And for this reason, there is a little a decreased efficacy of the vaccine against the Omicron. But nowadays, we can say that the vaccine are able to provide a protection from the severe disease and from death. And on the other hand, the Omicron has a very high transmissibility, but the disease that provide is rarely severe. But in general, let's talk about how do a vaccine work, because it's very important to have the basic knowledge about it. So when a pathogen or a part of it penetrate an human organism, it causes a cascade of events that are very complicated to explain. These are a complicated concept for us too. So at the end of the day, we have the activation of immune system. Cells and antibody are involved in that process. But the aim of the activation is the neutralization of the pathogen and the creation of a kind of memory about the pathogen. So in case of a reinfection, the immune system will recognize and will eliminate the pathogen in different ways. At the end, the aim is the neutralization and the avoidance of the infection and the disease. Right. In this case, we don't have pathogen in the vaccine. We have neither part of it, but we have the strain of the genome, DNA or RNA. So if we give some information, like this set of information to a cell, the cell behaves like a factory. What does it do? It translates the genome into proteins. And guess what? The genome is produced in spike protein. So if we produce in the human body a protein, a strange protein, a protein that doesn't belong to the organism, that organism, we have an immune system stimulation. So we incorporate the genome into a cell, but not into the human genome. Later, my colleague will talk about it. But at the end, we have the production of the spike protein. The little strand of DNA and RNA is eliminated by the human body. So we don't have any piece, any rest of this little part of genome. But we have the spike protein and the immune system stimulation and the production of antibodies against the spike protein. I think that this is a little bit hard to explain and maybe to understand. I hope if you have some question, you will do it at the end of this presentation. And let's talk about, Marco now will talk you about what should we expect from the vaccine nowadays.
Okay. Thank you. I'm going to connect to what Alexandra said to answer one of the questions. So what we expect and not expect for the vaccine against COVID-19. Okay, let's say that what we expect for the vaccine, we actually achieve what we expect, because we make the vaccines not to erase the virus from our lives, because I'm going to talk it later, it's kind of very, very difficult, let's say almost impossible to erase the virus. But what we expect was to create an environment in which we can live with the virus without getting the severe disease. And this, as you can see in this graph, the incidence of COVID-19 in vaccinated people compared to unvaccinated people, it's quite evident. So if you get vaccinated, you're not getting, or you're getting much less COVID-19. This is data from America, but if you take the European ones, are almost the same. Vaccinated cause a reduction in rates of COVID-19. And the other graph show us is the most important, in my opinion. Oops. Sorry. Am I avanti? In this graph, in my opinion, is the most important one, because this is the shown in how to convive with the virus. This is the rate of hospitalization, comparing the people who getting vaccinated, the blue line, and who's not getting vaccinated. And as you can see, this is an enormous difference between the two populations. So getting vaccinated reduce a lot the risk of getting hospitalized, and getting hospitalized is our way to say that the disease is very harmful, it's very dangerous. If you're not getting hospitalized, it means that the disease is very is not harmful, and the infection is getting less dangerous nowadays. Right. Okay.
Sorry, very sorry. I had a technical problem. So it's what we know about the vaccine. It's what Marco said. So we have the possibility to reduce the severity of the disease and death too. So the number of people admitted to ICU hospital care is decreased in a very strong way. But we nowadays know that it's possible through the vaccination, the mass vaccination, it's possible to reduce the transmission and so the spread of the pandemic. There are two very big studies performed in USA and in Israel that has shown us that a people receiving a vaccine has a very low possibility to take the infection only after 2 weeks after the vaccination. only with one dose of vaccination. So this is a very important thing, I think, because we can surely prevent the transmission to all the people. And if I can't get the infection, I can't transmit it to other people. But another very interesting item is what should we not expect? And you have voted a lot to allow us to speak about it. So please, Marco, go ahead.
Okay, so what we should not expect from the vaccine, this is not an easy question, so I reverse the thing, and I will talk about some myths that goes around vaccination, and I want to explain why these are not possible. The first one that I heard a lot is that the vaccine caused COVID-19. This is actually impossible. Alexandra explained you how a little bit of the vaccine works, but the vaccine doesn't. All the vaccine we had, all the one we had around the world, doesn't work with vital virus. It works only with a part of the virus. Typically, the most common work with mRNA that gets inside the cell and produce the spike protein. So it's absolutely impossible that the vaccines cause COVID-19. Sometimes you get symptoms that are quite similar to the first part of the infection, but that's our immunological response to the vaccination. So it's like a proof that the vaccine is working, but you're not in any way there's no way you can get in COVID-19 by vaccination. Okay. The other like myth we can hear about is that vaccine alter our DNA. This is again impossible, because even mRNA vaccines, you know, they put this mRNA in our cells, but they put it outside the nucleus, and our DNA it's inside the nucleus. So there is no way that mRNA will enter the nucleus of the cell. Biologically impossible. And other thing is that the vaccine or the mRNA will be translated in a protein, in a spike protein, and then our cell will delete this DNA from our cells. So the vaccine will work like for a few hours, a few days inside our bodies, but then there will be no other let's say the mRNA that we put inside will be no more detectable, and the only thing that will remain is our immune response that will last for some period, depends on our body, but there will be no possibilities to alter our DNA. And the other main topic is that vaccines can cause autism, all vaccines, but COVID in particular. And this is the story of this myth is quite old, and is a story of, let's say, greed of a man, because a gastroenterologic, if I'm not getting wrong, an English gastroenterologic published a study in late 90s in which he connects vaccine to autism, and this get kind of it becomes more and more relevant around the world. They say maybe there's a problem with this thing because the study was showing this relation between vaccines and autism. But then they made they take this study and they like check it, and they discover that he altered the results to make this connection, and then they take it away. The study, it took a lot, but in early 200 they take away this study because it was a fake study, and they discovered that this man, this doctor, was paid by lawyers to make this study, to alter it, because they need a scientific basic that will support a series of lawsuits against the pharmaceutical companies that make this vaccine. So to win the causes, they need some medical basis to win this cause, and they pay the doctor to do that. And furthermore, they discovered that this doctor made even like his own vaccine, different from this, the one he wants to destroy, to make money. So it was all about money. But this study was like they made a lot of studies after that one that show no connection between vaccine with all vaccines and autism, but this one was the one that remains in our memory and caused this this might to still be. You see here, I put that 16% of parents that has a baby with autism problems believe that vaccines is their cause because of this wrong study and the greed of that man. And the last might in this case is not something I will hope that it was like this, but it's not possible. So COVID vaccine can erase SARS-CoV-2 infection. Actually, this is in this moment it is not possible, because as Alexander told you, SARS-CoV-2 is a virus, is an RNA virus, and it is not the most the virus that has the most high incidence of mutation, but it mutates, and this mutation make him very easily capable of avoiding immune system, and this leads to the impossibility for now to the vaccination to erase SARS-CoV-2 infection. We erased disease, we erased one disease, the smallpox, in 1979, but because smallpox was a very stable virus, it didn't change itself, so it was easier to eradicate. We can eradicate some virus. Polio is the next target. It's eradicated in around 90% of countries, and is another very stable virus, and vaccination can eradicate polio, but actually we can't eradicate SARS-CoV-2 infection. The most likely scenario is a contest in where we virus will become endemic, so we'll make a little bit of endemics like influenza does, and we have to convive with it, we have to live with it. Okay, then we go to another big topic. A lot of you ask us about this question. So when we're going to use antibiotics in SARS-CoV-2 infection, when is appropriate? And if you ask me when it's appropriate, the only answer I can say is never. It's never appropriate. And to explain this, I hope I'm not offending you by say obvious things or things you already know, but if you ask me, if there is a lot of people ask me this question, maybe I need to explain some basic concepts about infection disease. These four are the main cause of infection disease. 99% of the infection disease in humans and in animals too. And we have four main categories: virus like influenza, SARS-CoV-2, sorry, HIV, herpes virus. Alexander already told you what a virus is. It's something that can replicate only inside a living cell of an organism. It can't live very much outside a cell because it can't live by himself. He needs to replicate inside another cell. It could be a human cell, it could be a bacterial cell too, but he has to live inside a cell. And the treatment for virus is antivirals. So if you have to treat SARS-CoV-2, we have to use antivirals, not antibiotics, because antibiotics is the treatment of bacteria. Bacteria is a mostly free living organism. And this one of the, let's say, bacteria is not all the bacteria cause disease. We have a lot of bacteria inside our body that is like, let's say, good bacterials, like the one we had in our intestine, that is the microbiota. And bacteria can live outside the organism, like Staphylococcus aureus live on our skin, and it doesn't need to enter our body to live, or Clostridium can live everywhere without getting inside a body. But some of them, when they get inside the body, they make a disease. And usually the disease caused by bacteria need a treatment, an antibiotic treatment. The difference between the virus and the bacteria is that the virus, we don't have a lot of antivirals. Most of the viral infection, our body, let's say, they defeat the virus by itself. It's much more difficult to defeat the bacteria, so we most of the time need antibiotics to defeat the bacterial infection. Then we have the other two, let's say, groups, fungus. It's difficult to get an infection of fungus in an adult healthy person, because we have a lot of natural defense against fungus, except for skin and mucosis, where you can get easily candida or something like that. But it's easy to get severe from fungus. But if you have some immune disorder or you get other disease, you can get fungus infection. And the treatment for fungus is antimycotic. So as you can see, every class has its own treatment. And the last one, the less common one in Europe, are parasites, that are organisms that sustain contact with other organisms to live. These are the biggest one, because in some cases, like Tania, you can see it by your own with your eyes. The infection, it doesn't need to enter. Obviously, some of them doesn't need to enter a cell. They live outside, and we have a treatment for parasites too that is antiparasitic. So as you can see, antibiotics can't be used on virus because they don't work. Specific treatment for bacterial. So if you ask me when it's appropriate to use antibiotics in COVID, the first answer should be never. But you may know that we use antibiotics in people who get COVID, but we use it when we suspect a super infection. What is a super infection? Sometimes when we get a viral infection, it's associated with bacterial infection too. In first, at the beginning, because the virus can reduce our defenses, and so it's easier to get a bacterial infection over a viral infection, and this is called super infection, because you get two germs at the same time. Sometimes could be even other fungus, or most common are virus and bacteria together. And if we suspect a super infection, that's the only case in which we should give antibiotics. These are the factors associated with COVID-19 infection, so viral, and associated with bacterial. It's not very easy, actually. Okay, if we can perform an X-ray, or we can do blood test, or we can do other exams, it's much more easy. So if you go to the hospital and take an X-ray and a blood test, it's much more easy to differentiate between viral or bacterial infection. But if you stay home, sometimes it's less easy. So if you have the suspect, or if the people are like fragile people, you use antibiotics in order to treat the bacterial infection over the viral infection, even if you're not sure. And the type of antibiotic depends on several factors: age, comorbidities, hospitalization. It's a medical decision. I can't tell you which is the correct antibiotic, because it depends on where you get the other infection and and depends even of a lot of things. But I want to be clear on this part. The treatment of COVID-19 is not antibiotic. We will talk later about what are the actually what are actually the drugs that we can use for treating COVID-19, but antibiotic is not one of them. Antibiotic is the treatment of the bacterial infection that could super infect COVID infection, but this is not the is not the routine. I bring you some data about how common is the co-infection, and as you can see here, in one meta-analysis I found the co-infection, so the infection of virus and bacteria in the same time was identified in 3.5% of patients. And the secondary bacterial infection, so a bacterial infection that comes when the viral was kind of resolved in 14%. So you can say, okay, 14% is kind of a big number, but I took another study in which, as we can see, bacterial lung superinfection, uncommon cause of death in people with COVID. So it's not the problem, the bacterial infection. We can treat it, but this is not how can I say, this is not an excuse for giving antibiotics to everybody, because and I want to underline this problem. The abuse of the overuse of antibiotics is leading to one of the biggest problem in infection disease in next years, that will be antimicrobial resistance, because as I told you, the treatment of bacterial infection is antibiotics, and bacterial infection are the worst infection compared to the other, let's say, in some case. And if we run out of our weapons against bacterial infection, we have a big problem. And this is going to happen if we continue to overuse antibiotics, because the risk of increasing antimicrobial resistance is a big problem nowadays. Okay. I think maybe we run a little bit too fast, but if you have questions, we are happy to answer.
Yes, Marco, there's a question from the floor from Ms. Martina Rimmele, who asked, in post-COVID syndrome, the patients have no positive COVID antigen test results anymore, but strong symptoms, sometimes severe. Do they still have virus titers that keep up the disease symptoms? Do they have too little antibodies to combat the disease? Thank you.
Okay, I think we're gonna answer, because in the next presentation, we're gonna talk about post-COVID syndrome and long COVID syndrome. So maybe we answer the question in the next presentation. Because in the next presentation, we're going to talk about post-COVID and the treatments of the actually treatments of COVID. So maybe we're going to answer this one in the later presentation. If we don't answer it, we ask us again at the end of the next presentation. So we're gonna say it again.
Okay, we'll keep it for later.
Okay.
I want only one thing. We can't, how can I say, we can't measure the load of virus in the human body with the test we normally use. The test is not quantitative, but it's qualitative. So we can say only yes or no. Yes, there is or there isn't the SARS-CoV-2 in the body. So if I have understood the question about the virus titer, we cannot say it. Okay, we can find it or not. Is that clear? Marco, what do you think about it?
Okay, it's clear. But yes, but I think I know what you mean. Like we can like test our
how much virus
we are protected by testing how much antibodies we have. We had a lot of studies that say that this is impossible in COVID-19. So the second part of this answer that maybe okay. The second part of this answer that maybe we don't talk it later.
No, the PCR, there is another question. Not even with the cycle number. No, the amplification of PCR is necessary to, how can I say, to
the virus.
Is the same. We have when we amplify the genome of the virus, we do it to find it. Okay, if we need a low rate of amplification, it's due to it's because it's easier to find it. It's not only for the quantity of the virus. It's not a direct relation between the two aspects. It's not it's not only about the virus load, not only that, but normally now we perform the antigen test. So it is, okay, I hope I was clear. It's important to understand because it's the same for the immune from the antibodies. We cannot be precise with the load of the antibodies, and there is not a strong relation between the load of the antibodies and the immune capacity to neutralize the virus. Okay, I end.
Okay.
So Marco, is the first part completed?
Yeah, maybe the second one is much more longer, so we
Okay, so
Yes.
okay, thank you. Apparently there are no other questions from the floor, and I would like to remind you that you can ask questions using the chat box indeed. And also I would like to remind you that all the presentations you will see today will be uploaded on our website in the coming days and also disseminated through our monthly newsletter. If you have not yet registered to receive it, you can do it by using the link I will put soon in the chat. And also, I would like to take this opportunity to thank all the connected participants, among whom there are representatives of patient advocacy groups from several countries, actually. So Poland, Netherlands, Croatia, Kosovo, Lithuania, Slovenia, Ukraine, Italy, Malta, and then Hungary, and Sweden, but also representatives of the European institutions, the media, private sector, and healthcare professionals. So I'll leave the floor to our two speakers. Thank you.
Here is it. Wait a moment. Sorry, I can't touch the pod. I'm not succeeding. Marco,
Hmm?
do you want to try? Because non riesco a toccare il pad. Ah no, ecco. No,
Sì,
ci sono.
sì, però sono andando.
Non mi fa tornare. È bloccato. Ok, ok.
Okay. Okay, we start with the part in which we focus on the treatments and on the consequence of the disease. And I will start again with some little bit tips again, something like the one before. I want to underline the difference between bacterial and infection. In this case, I want to underline the difference between infection and disease. That is not very easy because we made a lot of medical terms to say something that is quite similar. But I want you to have clear that this difference, because the infection is when a virus or a bacteria, but in this case a virus, enter in the body and multiplies in self-replicate there. It can cause harm to an hospital. It can cause harm to the host, and that one is the infection. Infection may cause symptoms that are related to more to our defensive than the virus itself, and this symptom can be clinically visible, or maybe cause no symptoms and be subclinical. So you get an infection, you didn't notice anything about the infection, and you erase the virus and you didn't know about it. But the disease is the consequence of the infection. Disease can be everything, but in this case, infection disease, it's caused by an infection, and you lost the functional state of the organism. The main difference is that in the disease you have damage to the function of an organ, like a pneumonia. You have a damage to your lungs, and you get a disease that is called pneumonia that can be caused from severe infection disease like COVID. I want to underline this one because when we talk about vaccine, their efficacy is on the disease, so they prevent the infection going into disease. And when we talk about treatments too, we're going to talk the treatment of prevent the disease. Preventing the infection is possible, but it's very difficult. Okay.
And we're going to talk about the disease or the symptoms of this disease. I have to underline that Omicron variant often give an asymptomatic infection, but when the disease is it's present, so when there is an alteration of the function of the cell, Omicron in particular give mild symptom disease. The consequence of this is the very low rate of hospitalization, in particular in ICU section of the hospital, and in general out of the hospital too. So when people remain at home, few patients needed oxygen support in comparison with the other variant. So what we see in that figure are the main representative symptoms. So symptoms due to the viremia, so because of the circulation of the virus in the blood. So fever, fatigue and body pain are common to other kind of viral infections. But in particular, we have upper respiratory tract symptoms. But why? Because we already talked about the spike protein, and the spike protein return in that field because it has an affinity to upper respiratory tract cell. So we find a big amount of virus in the upper respiratory tract because the RBD, the binding protein that bind cell, prefer the upper respiratory tract cells in comparison with the other type of variant of concern that have higher affinity for the lower respiratory tract cells. So it causes, for example, bronchitis, pneumonia, but the Omicron variant causes prevalently cough, rhinorrhea, congestion, and hoarse voice and a sore throat because of the affinity of the spike protein to those cells. But not only respiratory tract is affected by the Omicron variant, we could have gastrointestinal symptoms, and this is very and it occurs very often. Gastrointestinal symptoms are present in almost 50% of infected population, and in particular in the pediatrics patient age from 5 to 9 years who are infected by Omicron show diarrhea and abdominal cramps. It's not severe, these are not severe symptoms, but often we see patients with this kind of symptom like heartburn, constipation, diarrhea, and abdominal pain. We cannot talk about the pathophysiology of the symptoms because there is not only one mechanism that causes these symptoms, but this is a very multifactorial effect. For example, for the direct cytopathic effect of the virus on the cells, cytokine release that occur in all the organism, local and systemic inflammation of the organs, and an alterated metabolism, and at the end, what the alteration of the microbiota that Marco nominated. So this is important for the numbers because has a very high it occurs very often, right? So it's important for that and not for the severity. But there are all other kind of symptoms that affected people with the SARS-CoV-2 infection. And in particular, during the pandemic, we face a very high increase of acute cardiovascular events. In this case, too, there are many reasons for this kind of effect. For example, the prothrombotic effect of the COVID. The SARS-CoV-2 infection causes the production of blood clot in the vessels. So it can directly cause the acute cardiovascular event, in particular in people with high or very high cardiovascular risk. For example, people affected by hypertension, diabetes, kidney injury. In this case, is very high risk to develop a problem like that. But there are also other factors that cause an acute cardiovascular event. But at the end of the day, we can say that these are not the only reasons, because there was a critical degrees of follow-up of chronic cardiovascular disease. And we know that the follow-up is necessary to avoid the acute consequences of the a chronic condition, a chronic disease. So people not underwent normal programmed follow-up have a very, very high risk to had a very high risk to develop an acute cardiovascular event. And we know that in that period, in the pandemic period, people had a big concern about engaging with hospital and healthcare system. So there are that many factors that has produced these numbers. But what you can see in that figure is it appeared the contrary. It seems to be different from what I already said, because we say that the number of admission for myocardial infarction in 2020 is lower in comparison with the 2019. And this is because of the people concerned to be admitted in the emergency for cardiovascular acute symptoms. And this is very alarming, because we can't think that the number of people, not the number of people in general, but the prevalence of disease as myocardial infarction is reduced in that period, but the number of admission in the hospital is quite enough in comparison with the previous year, and this is very alarming. Only 2 words about the neurological involvement. In the beginning of the pandemic, anosmia and ageusia were considered like specific symptoms of COVID. Nowadays, we don't heard about it, but not because there is not a neurological involvement, but there is a neurological involvement, and it is related to direct and indirect damage of CNS, and but the symptoms are different, because different is the affinity to the cell of the, guess what, spike protein, and the main symptoms are seizure, dizziness, and headache. Maybe we're going to answer to a lot of questions talking about long COVID. Marco, please.
Okay, I'm gonna try to talk about long COVID. That is a big argument in the post-COVID pandemic. Okay, let's start with definition. Is defined as the continuation or development of new symptoms 3 months after SARS-CoV-2 infection, with this symptom lasting at least 2 months with no other explanation. The data regarding the incidence of the disease shows that around 10 to 20% of people infected by SARS-CoV-2 may develop symptoms that be diagnosed as long COVID. And the interesting part in is kind of answering the first question is there is no relation with severity of COVID-19, ECU admission, long hospital stay, immune response. We don't know exactly why some people develop long COVID and some people do not develop these symptoms. Why? Sorry, we made one only presentation, so sometimes we had problems with slides.
Questo è il caso, che si è bloccato completamente. Ecco
Okay.
qua.
Another way of defining long COVID, just to be clear, acute COVID infection is up to 4 weeks after developing the symptoms. Then we have ongoing symptomatic COVID from 4 to 12 weeks that are the symptoms from acute that continue. And then we have post-COVID syndrome that are the symptom developed during and after infection that continues for 12 weeks. There are only different definitions of long COVID, just to be clear that you can hear long COVID, post-COVID, outgoing COVID. There are like just medical terminology to define the definition of the symptoms, but the symptoms are quite all the same, and we will see some of them, you know.
Di nuovo.
Okay, this is some of the symptoms related to SARS-CoV-2 infection, and then that can define a long COVID. Alessandra already told you about cardiovascular and gastrointestinal syndromes, and she told you that the most common symptoms related to long COVID are mental symptoms like anxiety, depression, sleeping disorders. Fatigue for sure is one of the most common related symptoms of of long COVID. But one of the other and the main cause that force people to go to the doctor is persistent cough. That is one of the kind of big problem in long COVID infection. But then we have even a lot of problems related to nervous system, and in my patient that are old patient, we have a lot of memory problem and headache problems. Even in people, if people already had the memory problem, they get worse after COVID, and even people that don't have, they start to have memory problem after COVID in long COVID symptoms. Another problem is joint pain and muscle weakness. That is another kind of problem in old people. It's a big problem because it leads to immobilization. Immobilization is a big problem in older people. As I told you, we don't know. Oops. We don't know why. We don't know why this happened. There are some hypotheses, and I'm gonna try to explain the most, let's say, accredited hypothesis on why we have long COVID syndrome, because it's not easy to understand why we have it. The first one is an immune dysregulation. So we don't defeat completely the virus. That continues to lead a persistent small infection, maybe not big clinical symptoms, but it stays like undercover a little bit, and it continues to infect the cells. This, we know that a lot of viruses do that, like herpes. We know that herpes still live inside our body and react and do some reactivation sometimes. It looks like in some people COVID continue to replicate in small numbers, and this leads to immune dysregulation. The other big, let's say, hypothesis is the dysbiosis, so an alteration of microbiota. We already talked about that, but we know that microbiota is very at the center of attention for its role in some disease, not only gastrointestinal disease, but studies that relate this dysbiosis to diabetes or cardiovascular problems. So we know that an alteration or our microbiota can alter a lot of organs, the first thing we think about is gastrointestinal problem, but there are even some endocrinal problems that can be related with microbiota dysbiosis. The other theory is related to autoimmunity, so that the virus can activate or stimulate an autoimmune response of our cells. Autoimmune means that our immune system attacks the good cells of our body, and this can lead to the most common immune disease, but even to other problems. Seems like it in some people, maybe that are already have a predisposition, but virus can lead to an autoimmune response that can cause the symptoms of long COVID. The other theory, it's something Alessandra already told you, that the virus can cause vascular problems. So it in blood clotting and in endothelial abnormalities that can cause microvascular damage. Microvascular damage is not always something we can see, but is something that if it involves a lot of vessel can lead to an organ damage, because if we cut the resources even from small vessels to our organs, we have a dysfunction, and this is one of the other cause of long COVID. And the last one is that the virus interferes with neurological signaling, and this could be the cause of maybe memory problems or neurological problems. We don't understand exactly how, but it looks like the virus dysregulates some of our brain system or nerve transmission, and this could be a cause of fatigue or other symptoms of long COVID. In the next slide, I try to put all the let's say the symptoms and their pathological cause. You see here we have all the organs affected, and I don't wanna I don't want to focus on each of them, but just to make you know that long COVID could be almost everything. That's why it's even difficult for me to talk about long COVID, because it depends on which symptom we will develop, but we saw really almost every symptom after COVID infection, so it's even hard to define which symptoms are related or not related to long COVID, but actually virus can go everywhere, and with all the disorder we talked before can happen everywhere, so all these symptoms can be long COVID. It's possible to prevent long COVID. Actually, yes, if you don't get COVID, it's impossible to get long COVID, but it's kind of obviously an easy answer. But there are also evidence that people who get vaccinated are less likely to develop post-COVID syndrome. This is the only thing we found that is related to preventing long COVID, because as I told you, we don't know about we can't relate long COVID with our immune response, with our viral load, without our hospital stay or anything, but people get vaccinated are less likely to have post-COVID syndromes. Are there any treatment for long COVID? Actually, there is not a specific cure for long COVID, because we saw that everything could be long COVID, so it's difficult to have a medicine or the treatment that is specific for such a various disease. We have treatments that can help you feel better depending on the symptoms. On the symptoms, And for this reason, many hospitals in Italy for sure, but in Europe, but even in Europe, build a team of health professionals that involves doctor, physiotherapist, nurse, that can help you with the treatment of long COVID, in the meaning that not only medicine could be the treatment, but maybe physiotherapy could be a treatment, maybe psychological treatment could help you in long COVID syndrome. So there are not treatments for long COVID let me say, there is no one treatment for long COVID, but there is something we can do for every symptoms of long COVID. Okay, now we're gonna talk about the main, let's say, part of this presentation. So the treatment of COVID. In this case, I'm gonna talk about COVID-19 disease, not long COVID. I'm gonna talk about all the main drugs we use now, we had used in COVID-19. And the first slide you can see here, this is the authorized drugs in Europe for COVID-19. The colors, the green ones are antivirals. The yellow one are, let's say, anti-inflammatory drugs. I'm gonna explain it better later. And the blue one are monoclonal antibodies. This is I can understand this could be a different image, but I don't want to go specifically. I just want you to understand that we can treat the disease by 3 levels. The first one is that we can try to prevent the virus entering the cell, because as Alessandra told you, virus must enter the cell to replicate and to survive. So if we prevent the virus entering the cell, we stop the infection actually, because the virus can't even replicate. And these are the target of anti-spike monoclonal antibodies. So these drugs work preventing the virus for attacking the membrane and entering the cell. Then we have the antivirals, so not the antibiotics, but the antivirals that are as I told you, the specific treatments, and they work on different level on the viral replication, and they block the replication of the viral in different ways. I don't want to be specific because it's very hard to understand how they work. You just have to know that they block the replication of the virus. And then the last one, the last option is to prevent the manifestation of the disease. So when the virus is replicating, we know that we have a massive inflammatory response to the virus, and this can lead to the severe symptom of COVID. So we have some treatments that try to block the immune activation that lead to inflammatory, let's say, disorder that cause the disease. And we will see that treatment later. Okay, let's start with anti-spike monoclonal antibodies. That these ones were maybe the first specific treatment for COVID that comes out. And monoclonal antibodies is used to treat a lot of disease, and as the big how can I say, the big advantage of monoclonal antibodies are that they are super specific. So they attack only the spike protein of the virus and prevent them virus to enter in the cell. This super specific, let's say, target make them very, let's say, with little severe side effects, because they are super specific. They don't have a lot of side effects. So we can use it for preventing the virus entering the cell. So we have to administer them very early in the disease, because if the virus start to give symptoms, start to give severe symptoms, maybe it's too late. So they are appropriated only for treatment of not severe infection. So if you need oxygen, you are too it's too late, because if you need the oxygen, you already have a damage, so you already have the disease, so they don't work anymore. And the other good thing about monoclonal antibodies that we have studies that shown their efficacy even to prevent the infection, because as I told you, they prevent the virus to enter in the cell. So if you give it to people who don't have a SARS-CoV-2 positive test, but they have a contact with people that were infected, they prevent them from getting the infection. So they are the only ones that can prevent the infection. But the problem is that as I told you, they're very specific for okay, they are very specific for spike protein, and as Alexandra told you, Omicron variants have they modify the spike protein, and so all the actually monoclonal antibodies that we have doesn't work on Omicron variants. And unfortunately, Omicron is the dominant variant in Europe, so actually we don't use monoclonal very much, because despite they are very we are very comfortable with side effects, and they are kind of good efficacy, they don't work on Omicron, so we can't use them anymore. So we have the most common drugs actually used is antivirals. Okay, antivirals are the specific drugs for prevent viral replication. We actually have 3 antivirals approved for SARS-CoV-2, and there are Paxlovid, that is the commercial name of a combination of 2 antivirals that are difficult to pronunciate, so I will use the commercial name. Paxlovid is highly efficacious. It's kind of easy to use because it's in pills. You have to take around 12 pills a day, I think, or something like that. You have to take a lot of pills, but there are pills, so you can take it home. But it works kind of well, but you have to give at the beginning of the infection, but it works. The big problem of it is that he has a high drug-to-drug interaction. So I'm talking about my patient again, so old patient. I think only 1 on 10 would take Paxlovid, because he had a lot of interaction with other pills they take. And the other problem is that you have to have a good renal function, good hepatic function. So this, like, let's say, limits its use in only a small part of patient, despite of its effectiveness. Another antiviral that is kind of used is the remdesivir, that was one of the first. It's kind of effective. It doesn't have too much drug-to-drug interaction, so it's easier to use, but the problem is that it's only EV, so you have to go to the hospital and they have to give you he has to have an EV infusion in 3 consecutive days, so it's not very easy. It necessitates you to go into the hospital and be admitted to the hospital, so that's the problem with remdesivir. The last one to comes out is molnupiravir. It's in pills again, so it's easy to take, and it doesn't have too much drug-to-drug interaction, so it could be the good one. The problem is that it's not very efficacy. It's not very efficacy, and we discovered that in the last HEMA publication is about like 2 weeks ago. They say that molnupiravir is no longer authorized for treating COVID because they found out that Lagevrio is the commercial name of molnupiravir, doesn't reduce hospitalization or death or the duration of the illness or the risk of severe disease. So it doesn't work actually, because they compare with placebo and they notice that it doesn't reduce death, doesn't reduce hospitalization, doesn't reduce the duration and the severity of the disease. So it was no more possible to say that he has a clinical benefit of using a drug that actually have some side effects, not so much, but he has some side effects, and it doesn't reduce all these things. So it is no longer in the treatment of COVID-19. The other way of treating COVID-19 was to block the let's say the inflammatory response consequent to the viral infection, and we used to use two immunomodulator. There are again monoclonal antibodies that blocks one way of transmitting the inflammatory cascade. If you have any question, I will try to explain later. I put this picture on the right to explain what they do. Like when we inflammatory response, we activate a signal that maintain this inflammatory response. These modulators block the signal, as you can see there. The blue, let's say, circle stops the receptor and blocks the receptor, and it can no longer transmit the signal. We used two immunomodulators during COVID pandemic. That was anakinra and tocilizumab, that was used for other disease, and we tried to use in COVID disease, but anakinra is no longer used since in January 2023 is getting out of the recommendation of the guidelines against COVID-19. Tocilizumab is still used in very severe critical COVID cases, so the one in intensive care unit requiring oxygen supplementation, but it's not so effective because it blocks one way of transmitting the inflammation problem, let's say, but there are other ways, and there are other ways that the virus damage the cells, so is not very effective actually, so we don't use that very much. Then we have another drug that is not in the first panel, but we use it actually, and it's corticosteroids. Maybe you heard about it because in the first part of the pandemic they would use quite a lot, but then they discovered that using too early will like lead the virus to spread much more. So now we use corticosteroids only in severe infection. So when the patient saturation is below 94%, or when patient require oxygen supplementation, or is in intensive care unit under mechanical ventilation. So we use it, but in few selective cases. I don't put a slide on funds, but even that ones were used in the first part, but they don't have much use in the treatment of COVID. It's more symptomatic drugs. I'm going to talk about some drugs that were used at the beginning of the pandemic, and they were on the newspaper. They talk a lot about these ones, and I want to talk a little bit about them. The first one is hydroxychloroquine. That was the first drug that they start to say you have to take it to treat COVID. Even Trump take it, and they say that because they have some in vitro studies that show that hydroxychloroquine inhibit SARS-CoV-2 replication. But as most of the times happen, the in vitro studies doesn't transform in vivo studies. So hydroxychloroquine doesn't work. They did a lot of studies on hydroxychloroquine, and they found out that it was no effect on COVID-19. Some of them were stopped and discontinued their hydroxychloroquine arm because they see no efficiency of this drug. And the other drug that was used a lot at the beginning, maybe some of the other drug that was used a lot, maybe some of you have taken, is azithromycin. Azithromycin is an antibiotic, so as I told you before, it doesn't have any effect on virus, but azithromycin is a particular antibiotic that, and they say that maybe because of his mechanism, he has a low antiviral effect, and because of some studies in some lung disease, they show an anti-inflammatory benefit on the lungs. They say that maybe it could use to treat COVID-19 too, but actually they had a lot of studies again on azithromycin, and there were no any clinical benefit of using azithromycin against COVID-19. On the virus, again, if you have a bacterial infection over the virus, it can be used, but because it's an antibiotic. And the last one that was another very famous treatment is convalescent plasma. I think you hear about it. What's convalescent plasma? It's the plasma, so a part of our blood contain that have antibodies against COVID. So because it's the plasma taken from people who recover from COVID-19, and so they have antibodies against COVID, and they say, let's put the plasma of people who recover in people who have the disease for treating the disease. It wasn't wrong as a concept. We use that kind of plasma for other disease, but actually it doesn't work on COVID, unfortunately, because there were a lot of studies again, and they show no benefit of using convalescent plasma of people recovered from COVID in people who have COVID. So again, convalescent plasma is no longer used as a treatment for COVID-19. Okay. If you have questions, we can answer at the end. I think maybe my presentation was a little bit too difficult in some parts, so if you have any question, I can try to explain in the question moment. Now Alexandra will talk about the last part of our talk.
Let's change the topic of this lecture, because we are going to talk about what pandemic left behind, and these are data from European Cancer Organization that have estimated that 100 million cancer screening tests were not performed in Europe during the pandemic period, so in the last 3 years. We talk about screening about colorectal cancer, breast cancer, and cervical cancer. We know that the programmed and the routinary activity of the healthcare system all over the world was shifted to emergency activity due to the COVID patient. So it's easy to understand that all the programmed tests and visits and all this kind of activity were left behind. as a consequence, we have a very big rise of disease and morbidity and mortality due to this disease. This is a very interesting report of the IQVIA Institute named Cancer Won't Wait. And what do we find in that report? Data from in the date of March 2021 about the impact of the reduction of the screening, because of the reprioritization of health system resource. And we know that this is not the only reason why people didn't perform this control, but it's about patient attitudes and concern about engaging with health system too. It is easier to understand it because we talk about healthy people, people who don't present any kind of symptoms, people that undergoes control only for screening to detect disease that are not manifest. So all due to the prevention is a little bit more hard in this setting. If we think about the concern to get the COVID infection or a little reduction of the trust of people in the healthcare system for different kind of reasons. This is not the aim of this lecture, but we have heard about it in all this hard period. So all that aspect, cultural aspect, organization, reprioritization of health system are the reason why many people didn't undergo follow up. And these are the number in this case is very huge and very worrying. Let's take a look about this study. This is an analysis conducted in Europe and in US, North and South America. At the beginning of COVID-19 pandemic, there was a huge suspension of all the non-urgent medical services. In particular, on April 2020, there was a reduction near to 70% of the screening test in comparison with the other period. So 70% is a very huge number, but in the average, we have a lost 45% of lost screening tests. And it's easy to understand that it's due to cancer mortality for delayed diagnosis and therapies. This is not only about cancer, but all the condition that has to be detected in healthy people. But in the cancer, the consequences of the cancer are under our eyes, and in terms of morbidity and mortality. The same things we can say about the infection. If we don't look for the HIV infection, we can say that there's not HIV. And we know that HIV infection is not belong to the past, but it's a pandemic nowadays we have a very high number of people who don't undergo control of HIV, and the data that we can see in that slide is due to the 2020 in comparison with the other years, from 2011 to 2020. And in the West, Center, and East Europe, the number is very low. We don't have to differentiate the people, not the people, but the where do the infection come with the sex between men, heterosexual. This is not important. In general, we see that there is a very huge reduction of the diagnosis of the new infection diagnosis. So we didn't find it because we didn't look for it. And this is a very big issue that we have to face now and in the next year. But what is possible to do? What are the measures we put in place to solve this big problem? We have learned during the pandemic. We have learned a lot. The first thing we have learned is that we have to create network to solve the healthcare system problems. So all the stakeholders has to run together to solve the healthcare system problem. Altogether, patients, advocacy group, pharmacists, all the primary care, hospital, the private sector too, and all the government organization to carry out concrete actions to face it. We have to reprioritize and create new protocol because we're no longer in acute phase of the pandemic, and we have to organize and create new protocols due to the new problems, due to the delay in the screening and in the programmed control of people affected by chronic disease. So it's very important to use the technology in a better way. For example, using telemedicine or other technology to arrive to the people, to connect people in general, but I say patient, to the healthcare system, create a new trust, a new connection between them, and use it better to create communication and awareness in the patient. And use of the pharmacists, for example, that is considered at the margin of the healthcare system, but it is not. All the stakeholders are very important in that process. Let's take a look some selected example of action in different European countries. It's very interesting, for example, the Portugal way, because they organize breast screening mobile units to guarantee the screening execution. Maybe in more in little town, in place where it's not routinely performed. Or, for example, in France, the creation of a hotline that connects patients to the healthcare system, because it can occur that people have only have to be aware about it. I don't know if you have further information about your country, but I found this summarized very interesting because there are some inspiring information from different place of the Europe. In Italy, we don't have a protocol to solve this kind of protest just now, but it's very interesting to know that an effective triaging or overdue breast cancer screening to prioritize the people most at risk is performed, because there are people that have to have a priority on other people, because they have a very high risk to have a cancer, in this case the breast cancer. And we have finished with our lecture, but let's do a conversation about these topics that are I think in part very hard to understand. If you have some question, we're glad to
Sì, ce ne sono un po'.
answer.
Okay. Yeah. Okay. Thank you very much for listening us. We're gonna try to answer some questions. I'm gonna try, because some of them are quite difficult. So we're gonna try to answer. Okay. The first one asks us if there are if the diarrhea and constipation could also indicate that it's functional at neural level. Okay. We know that there are some connection between our gastrointestinal system and our, let's say, neurological system, because as you may have noticed, even we somatize very often in our gastrointestinal way. So it's difficult to answer this question. We don't know, because as I told you, the mechanisms of long COVID, if you talk about long COVID, are not well known. But I will say that it's possible, because we have this connection between our gastrointestinal and our neurological system way. So it may be even there are some pathologies, there are some disease that interest neurological, that can manifestate with diarrhea or constipation. So it may be, but I don't know for sure. I can search, but when I search for this presentation, there were only hypotheses. So I think you will not have a proper answer for this question. And then about the difference from long COVID, in long COVID from post-viral syndrome. This is another difficult question. Let's say long COVID could be a post-viral syndrome, because post-viral syndrome is a sort of fatigue and dizziness or something that you have after a viral infection, and it could happen after all viral infection, and its duration is variable depending on the individual. Maybe we can say that one of the manifestations of long COVID could be a post-viral syndrome, but difference actually I don't know if Alessandra.
Medicine, we used to give names to the things, but it's only a lexical
way.
Yes, there's not a wall between the two type of conditions.
Okay. Questa è difficile. This one is difficult. I don't know the role of microRNA in prothrombotic effect. I don't know, because maybe it's your but I know what microRNA is. It's something we have in all our cells, and it works like how can I say, modulating what kind of genes we have to express or how we express that kind of genes. But his role in cardiovascular system, I really don't know. I'm sorry, but this is too specific for me. I don't know. I answer this question because I don't know the role of microRNA in prothrombotic effect. I'm sorry, but this is too specific for me. Non so se tu sai qualcosa, ma...
No, nello specifico no. Beh, però noi parliamo di RNA messaggero.
I'm sorry. If you want to make a different question, but this one for me it's too difficult. I don't know the role of microRNA. It's something very new, the role of microRNA in our cells. And as what I know about microRNA was, I told you, it regulates some of the genes that if you refer to mRNA, is not micron, messenger.
Yes,
that's a different question, and there is no relation about mRNA with thrombotic effect. There were some relation between the other there were some hypotheses about the other vaccines and the prothrombotic effect that was
DNA
kind of individuals, but not the mRNA vaccines with prothrombotic effect.
And we don't know the mechanism that that cause the prothrombotic effect related to the DNA vaccine. Is not the DNA, but it's led to the patient, to the not to the patient only, but is the risk related to cardiovascular event, but it's not due to the mRNA. When we talk about mRNA, we talk about messenger. That is a kind of mRNA that we have in our cells. Maybe I didn't understand the question.
Okay, about the microbial studies that will, let's say, protect about severe COVID symptoms. I don't know if there are any studies. Maybe because we now microbiome studies are very popular, and as maybe you heard, we have even the microbiome transplant for treating some disease, even some infective disease like Clostridium. We take the microbiome from healthy people and we transplant to people who have that disease. So I think that there may be some studies about some microbiomes that are more, let's say, resistant to COVID, but I actually don't know if there are. I can check, maybe, but I don't know.
In the pandemic period, a lot of studies was performed, also with a very few patients. So we can find studies about everything, but the number of patients often is very little, is very not representative. So you can check on PubMed too and find everything about every topic, but you have to look after the number of patients undergoes the control in the study, in the clinical study. So we can find it, but I don't know if we find something representative, something relevant, you know. But we can check. There is another on long COVID syndrome.
Mm.
Pandas. No. Can't answer.
Mm. I see some.
I can't answer. I'm sorry, I can't answer about the pediatric issue. The question.
Post-tachycardial syndrome.
It's very specific. I'm not pediatric.
No, about the tachycardia syndrome, I know that there are some cases of tachycardia after COVID, sinusal tachycardia, and seems to be related with some neurological effect of the virus on the heart transmission, but is not something very usually is something like that doesn't give you any problem. There are cases, I saw a few of sinus tachycardia after COVID, but with no symptoms. Yeah, it's an abnormality of automatic nervous system due to maybe what I told before, some interaction of the virus with the transmission of neurological impulse.
Do you know this IBM Watson?
No, questo.
Never heard about it. But you talk about a prognostic tool to evaluate the risk of a severe disease. Because if we talk about the possibility of people to develop a severe disease, we have different kind of tools, and these are due to the age first and the comorbidities. But I don't know this specific tool or project.
I don't know if there are any other questions. Otherwise, Bianca, if you want to.
Okay, let's check one other. Okay. Okay, so no, apparently there are no other questions.
No.
No? Okay, so thank you again to our speakers for the interesting webinar and to all of you for participating in this webinar. I would like to take this opportunity to inform you also about the two next European initiatives that we will be organizing in April at the European Parliament in Brussels. The first one is the 17th edition of the European Patients' Rights Day, which will be held on April 26th and will be dedicated to the topic of ATMPs. And also the other one is the final event of the European Project Ahead, dedicated to the topic of medical desertification, which will be held on April 27th. To find out more, you can visit the links that I have just put in the chat. And as said before, more information, including about the possibility of registering to participate in these events, will be provided in the coming weeks, again, through our website and newsletter. So thank you very much again, and I wish you a lovely end of this day. Thank you.
Thank you.
Thank you. Bye.
Bye.